Okay, good morning, everyone. Welcome to High Rounds for today. We are honored to have Dr. Joel Wertheim give us a talk today. Let me just find his bio. Dr. Wertheim is an associate professor of medicine in the Division of Infectious Diseases and Global Public Health here at UC San Diego. He received his PhD in ecology and evolutionary biology in 2009. His research uses viral molecular epidemiology to track pathogen spread and inform public health action, focusing on HIV and SARS-CoV-2. So once again, we're glad to have him give his talk today. I don't know, Joel, if you're able to pull up your slides.
Let me do that real quick.
Yeah.
All right. There we are.
All right. And
Can
so
you
his
see that?
presentation, his presentation will be on genomic and social network analyses of healthcare and campus transmission at UC San Diego. So go ahead and take it away, Joel.
All right. Thank you. And thank you for inviting me here today. So this talk is something that it's based on research that I was asked to do by the university, tapped to help them understand transmission both within our UC healthcare system and on the campus. And we'll first just let you know who typically funds and supports my work, which is the New York City Department of Health, the Centers for Disease Control Prevention, and the NIH, although this work was unfunded and just done at the behest of the university. And is deeply indebted to the search program at UCSD and the broader San Diego area. Now, specifically, there are a lot of people who've been involved in both of these studies, one of which is very much still ongoing. So I just want to give a shout out to just 4 people real quick. Jocelyn Keener, who helmed the UC San Diego healthcare paper, and Francesca Toriani, who's a co-senior author on this project with me. And then when we get to but as you can see, many more names than I can read off had very large footprint on this project. And then as we move to the UC San Diego campus side, I just want to give a particular shout out to Robert Wood, who introduced me to the campus housing data, and to Natasha Martin, who spurred all of it along. Also to Cheryl Anderson, who's overseeing the whole project. Okay. So let's start with UC San Diego Health, which many of us are part of, although as a PhD, as Daniel mentioned, not actually a practicing physician, but I work right next door to the Hillcrest Hospital. So I feel like I have, well, that's the extent of my actual insight into it. But it took a little while in the pandemic for healthcare to catch up with the nature of COVID-19. But eventually, UC San Diego Health realized that there were 4 aspects that were important to mitigate transmission in the healthcare setting. These would be universal masking of both patients and healthcare workers, eye protection, routine symptom screening for all healthcare workers, and routine testing for all patients and healthcare workers. So the question that we want to ask here was there evidence of cryptic spread of SARS-CoV-2 in the UC San Diego health system? And were these mitigation efforts effective at preventing the spread of this virus? So basically, were COVID-19 mitigation strategies effective? So the data that we were able to assemble was quite impressive. So we looked at all people who were diagnosed with COVID-19 between the 1st of November 2020 through the 27th of January. Sorry, that should say 2022. And that would be all people who were either patients or worked in UC San Diego Health. Yes, 2022. This would be 1.3 million total PCR tests with over 35,000 PCR positive results, which produced whole viral genomes from 13,000 individuals. And then the sort of largest part of this project, which I'm going to cover very quickly, was an inquisition of all of the electronic contact records, which included any contact in Epic or any patient who shared the same room, any healthcare workers who we have electronic evidence of entering that room or treating that patient. We queried all of those. And among these thousands of people we know who had SARS-CoV-2, we looked for any of those interactions within the 2-week period surrounding their diagnosis to see if they had contact within the health system or another person who was diagnosed with COVID during that time period, which produced a total of 2,397 pair interactions. That's either 2 patients who shared a room, a nurse, doctor, or technician, or cleaning person who serviced that room, or 2 healthcare workers who were on the same shift at the same time. Okay, so, and what we did is we looked at about 5,000 of these genomes that were of high quality enough to look to see if there was evidence of transmission between these healthcare workers and patients. Now, when I look at SARS-CoV-2, this is what I see. It's about 29,900 or so nucleotides, A's, G's, C's, and U's, and which we can use to determine if 2 people who both had COVID-19 at the same time and interacted, if the viral genome sequence is consistent with the transmission event between the 2 of them. And if it is, we call this a genetic link. Now, importantly, a genetic link doesn't mean A transmitted to B or B transmitted to A, but it does mean that the genetic sequences are similar enough to be consistent with that epidemiological link that we see. And we went about defining these epidemiological links in 3 ways. The first was just to look for these pair-pair interactions where the 2 individuals had identical genomes. That means the virus didn't have time to mutate between infecting both of those individuals, which means it is consistent with transmission. But of course, we do know that SARS-CoV-2 mutates, so we allowed for linkage between nearly identical genomes. In this case, person 1 and person 2, their viral genomes differ by a single mutation. But that's close enough to be consistent with direct transmission of this virus. And of course, I added P3 in there to show that you could also have an identical genome in such a cluster. And then we also allowed for an unusual case where P2 and P1 and P3 may have all been linked in the electronic record, but P2 has many mutations leading to it, but no onward transmission from those mutations. And what this is potentially indicative of is either many mutations or a lower quality genome sequence. But we don't want to sort of remove that link just because we accidentally called 1 too many mutations in one of the genomes. So we allow people who are direct descendants of a cluster where they have an epidemiological link to be connected. And these are the 3 ways that we would define viral genomes as being consistent with the epidemiological data. So here, in the first part of the study, we're looking at the 2nd and 3rd wave of SARS-CoV-2. Now, I just want you to remember all the way back, all the way back to this, mid part of the pandemic. That's after the 1st wave. And essentially what we have is the pre-variant and variant wave. So when we had alpha and epsilon, followed by delta, but before Omicron. So our 2nd and 3rd wave of COVID-19 in San Diego. And we went and we built a phylogenetic tree, which you can see here, of all almost 6,000 viral genomes. And we went through and identified every person in that tree who had a contact in the electronic contact record. And we then look to see how many of those people were genetically linked. So everyone who has an electronic contact is highlighted here in green. And anytime that those contacts are genetically linked, that's identical or within a mutation or so of each other, we colored them blue. You can see the vast majority of people who had an electronic contact in the health system weren't genetically linked to their contact. Only in a small fraction of them highlighted in blue. And if we zoom in here in the very bottom corner, you can see one of those examples where you have three people who are genetically linked to each other. They're very, very close on the tree, indicating they have very similar genomes, and the electronic record suggests that they had contact in the health system. Now, it doesn't mean that they transmitted in the health system, just that they had contact there. All right, so in all, across these 5,000 people who had genomes in the second and third wave, we found 13 clusters that are groups of individuals who had overlap between the electronic contact record and their viral genetic transmission history. Now, I'm just going to go through these clusters for you real quick to give an idea of what we found. Well, out of those 13, 9 of them had evidence of household transmission in the community. These were all patients, and they had the same address or near adjacent addresses, meaning that although they all had COVID and they all came into the health system, say they both walked into the ER for testing on the same day, and therefore had contact within 2 weeks of their COVID diagnosis, they most likely acquired the virus and transmitted the virus in the community. And here's an example of that. This is what we call cluster 5. This was a cluster of 9 patients, all 9 of whom reported 2 residential addresses, which were very close to each other, indicating sort of an extended family situation. And although many of them had contact within the UC healthcare system, it is highly unlikely that any of them actually acquired the virus there, given that they all shared residential addresses. So this is a community-acquired infection that we see in the hospital system among patients. Okay, patient-only cluster, all members, family live together at 2 addresses. Okay, but we did find in the 4 remaining clusters contact within the healthcare setting. And this is indicative of transmission while care was being provided. Now, in 3 of the 4 of these healthcare clusters, they had previously been identified in part or in whole by contact tracing teams. So no evidence of cryptic transmission, but yes, there was transmission within the healthcare system. The first of these is cluster 1, which comprised 4 healthcare workers, shown here on a phylogenetic tree, or a very, very small part of a phylogenetic tree. You have 2 identical genomes at the base of it, and then 2 genomes that are each 1 mutation away, indicated by those short branch lengths. And then they're all square, so they're all healthcare workers. Now, as I mentioned, this was a previously known cluster. 3 of these healthcare workers, we found evidence of this cluster in the EPIC electronic contact records. And then 1 additional healthcare worker became known before we did this analysis, linked by the contact tracing team. Now, all 4 of these healthcare workers shared an office, and 3 of them were known to overlap in their shift work. So this is absolutely transmission within the healthcare system, although it doesn't necessarily seem to be during the provision of care, and we don't know when exactly during the workday transmission may or may not have occurred, lunches, for example, or in a room while masking. But this is evidence of a hospital-based transmission, but not one that we didn't know about beforehand. We get into cluster 2, and that's a bit more of a complicated cluster with a bunch of identical or near identical genomes with a mix of patient and healthcare workers. In this case, we know who we determined through the epidemiological tracing that the index case was a patient who arrived from outside of San Diego County. They were admitted to the hospital with a non-COVID-19 illness and were PCR negative upon transmission. They were then placed in a shared room and then discharged after 4 days, but within 24 hours of their discharge, were readmitted with COVID-19. Now, I think one of the most important points about this cluster is first, we knew about it before we conducted this analysis, which is how we know based on interviews with healthcare workers involved that this patient was consistently unmasked while in the shared room, while receiving treatment, and refused to adhere to COVID protocols even after their diagnosis. So we have a complete lack here of source masking. This cluster extended to the another patient within that room, so their hospital roommate, and 4 healthcare workers who cared for the index case and later tested positive. There is no evidence of contact to other patients in EPIC, so the extent of this cluster and why we see so many additional patients in this cluster is unclear, but they also could reflect community transmission, who later came into the healthcare system as San Diego, UC San Diego Health is a provider. But we do see evidence of transmission within the healthcare system, primarily due to, or seems attributable to a patient who refused masking. And the final cluster we see here of healthcare workers and patients is what we call cluster 4. In this case, we have multiple healthcare workers and patients, including one who is quite descended from this cluster, but not necessarily with a link to the cluster itself. Okay, so this again was a previously known cluster. There were 4 patients who were SARS-CoV-2 negative upon admission to the hospital, and all 5 of them shared a 5-bedroom hospital room in which these patients were often unmasked. And then we had 3 healthcare workers who were assigned to this unit and or cared for these patients, all of whom acquired SARS-CoV-2. So again, a known cluster within the healthcare system attributable to lack of source masking. And then we saw this transmission spread. Okay. And then the 4th cluster that we found within the healthcare system were 2 healthcare workers who worked in the same department, but their only contact in EPIC occurred 24 hours before they both independently tested positive. So we don't have any evidence of this being transmission or acquisition within the health system. Of course, at least one of these people acquired SARS-CoV-2 from a different individual, but based on the current epidemiological data, we can't identify this cluster as being transmission within the hospital because the disease timing and testing doesn't line up with viral transmission. Okay, this is important. Out of those 13 clusters I just presented from you, 0 of them showed evidence of cryptic spread within the healthcare setting, which is important because that means that if there was transmission, if there were clusters in the second and third wave, we knew about them, and we see no evidence for transmission that we missed, even though we know that both patients and healthcare workers were becoming infected with SARS-CoV-2 during this period of time. So it suggests that querying the electronic record system worked, and that when the mitigation strategies were in place, we seem to have prevented spread of this virus within the system, which I take as good news. But then he came along. Yeah, so this is actually the Greek letter Omicron. which, all these Greek letters look really fancy and are really nice to put up in slides. Omicron is just an O, so it's boring. So we'll give it its special phylogenetic designation here, BA1. And in this case, this was, if you remember, quite a time. So what we're going to focus on here is just that first part of the first Omicron wave, which happened between December 2021 and January 2022. Finally got my dates right. Okay, now in this time period, 1,376 healthcare workers within UC San Diego Health got infected. That's almost 1,400 healthcare workers in about a 6-week period. That's an 800% increase over what came before. And you got to remember the 2 months prior to this, that included the Delta wave. So in case you don't remember just how widespread Omicron was, it ran through San Diego like wildfire, infecting 2 to 3% of the population a day at its peak. And our health system was no exception to that. You can see here just how the confirmed cases during that short wave dwarf everything that came before it. The first wave, of course, we had poor testing, so we can't compare to that. But if you look compared to the variant waves and the Delta waves, Omicron was like a mountain compared to hills. Okay, so what we want to know is, the other thing about Omicron, and I'll zoom in here. So this was the genomic diversity pre Omicron. This is sort of the first wave of the Wuhan variant, Alpha, Epsilon, Gamma, Delta, all of that here shown on a phylogenetic tree that we did our analyses on, looking for genetic similarity. Omicron was a little different. This was the genomic diversity of Omicron during that first wave. Whole bunch of nearly identical genomes. So again, pre-Omicron, Omicron. And now we want to do the same type of analysis, except with far, far less diversity, meaning more and more people with nearly identical genomes. So in order to do that, we have to sort of blow up our tree and look at it very, very, very closely. But you can see that even still, so many people on this tree had identical or near identical genomes, which make this part a little harder, which is why we separated this analysis from the previous analysis. But before we get to Omicron, I'll just answer. I can hold that question for the end if that's okay. All right. So during Omicron, we have 7,800 high-quality SARS-CoV genomes from healthcare workers and patients, and we wanted to ask, was there evidence of cryptic spread? So we found 2,000 contact pairs within the electronic record, and 120 of these pairs had genetically related virus, which is a positive predictive value of only 6%. So again, that's 2,000 pairs of people with nearly identical viruses and only 120 with any chance of linkage, which means 94% of the people with contact pairs during Omicron in our health system had genetic evidence that these viruses were not involved in the same transmission cluster. So even though we're looking at thousands of people infected, we can say that most of them could not or did not acquire their virus within the healthcare setting based on the contacts that we establish in our electronic medical record. Right there, put it in print. So even in the face of an 800% increase and thousands of infected healthcare workers, we don't see evidence of this transmission. Now, we did see 89 links among healthcare workers, 25 links between healthcare workers and patients, and 6 links between patients. But remember that Omicron These viruses are nearly genetically identical, and some people could be genetically linked to dozens or even hundreds of other people who got the virus at the same time, which means odds are one of those people popped up in the healthcare system. Because if you happen to be in this part of the phylogenetic tree right here, you're looking at uh, a sort of 1 in 7 chance of the person who you have an electronic link with also having an identical genome to you, knowing nothing other than the number of people who had SARS-CoV-2 and a genome sequence at the time. So we're definitely going to see a lot of false positive links. And in fact, uh, if we were to randomly shuffle all of the contact records across that phylogenetic tree, we would have expected between 34 and 109 links among healthcare workers. We observed 89. Are some of those links reflective of actual transmission in the healthcare system? Almost certainly. Are they more than you would expect by chance? No. Same thing with the links between healthcare workers and patients during Omicron. We expected 21 to 62. We observed 24. The 21 to 62 is just based on the random, chance of having a similar genome during early Omicron. Some of these real, potentially, significantly more than expected? No. And then we see the same thing with patients. With these 6 links between patients, we'd expect between 1 and 11. So significantly more than expected genetic linkage among patients? No. So we don't see more linkage in Omicron wave than expected by random chance. That said, we think that some of these linkages are real because we found 10 clusters between healthcare workers, and then 4 clusters between healthcare workers and patients. That being said, it can be very difficult to disentangle with such widespread community transmission as to where these transmission events occurred. But importantly, there wasn't more than we would have expected, even despite that 800% increase in COVID-19 diagnosis. Okay, now I live and work down in the Hillcrest area. So I didn't motivate this analysis, but we did ask the question, what was the difference between the Hillcrest Medical Campus and La Jolla Medical Campus? And the answer is quite a bit. So most of our healthcare transmission events occurred in the Hillcrest campus, particularly among patients sharing a room. I walked through a couple of those clusters with you earlier. So 79% of our pairs during the second and third wave, they happened on the Hillcrest campus. 78% of those pairs during the Omicron wave happened on the Hillcrest campus. And this is likely reflective of how the Hillcrest Medical Campus was designed, and how it was not designed in the same way as La Jolla Campus to mitigate disease spread. But the giant hole 200 yards from my building would suggest that we are in the process of rectifying that situation here at UCSD Health. Okay. Here's the big takeaway from this. In my opinion, after looking at these data, UC San Diego health prevention strategies were effective at identifying and likely preventing SARS-CoV-2 healthcare-associated transmission. In the pre-Omicron wave, when we had contact tracing implemented, we knew about every large cluster involving healthcare workers and patients before the genomic investigation, meaning there was no cryptic spread of this virus, even though people were getting sick. They were acquiring it in the community. And during the Omicron wave, we also didn't see evidence of cryptic spread, which I think is very important. It means that when this virus was spreading around the community, we, as members of UC San Diego Health, as members of that community, got sick. I know I did. But that doesn't mean that we got it while conducting our work as healthcare professionals. And then finally, I think what's really important is that many of these transmission events were associated with the lack of source control masking, and that when source control masking was properly implemented, didn't see evidence of transmissions. And although this is not a sort of gold standard study of masking, it does indicate to us that our masking and mitigation protocols, when taken in combination, were effective. Finally, as I said before, Omicron was not spreading uncontrollably through the healthcare system. It was spreading uncontrollably through the county and the world, but our healthcare system was not propagating that transmission. And I think that's very important. That just because two healthcare workers or a patient and healthcare worker had COVID at the same time during Omicron doesn't mean there was transmission. And the genomic data backed that up. Okay. Now let's take a pause here, move away from what we all know and love, and move up to the campus, or the main campus, where our undergraduate and graduate students reside, here represented by our lovely Triton mascot. Okay, so for those of you who interact with main campus, you'll be very familiar, or actually headed the Return to Learn program, which was not a single policy, but a combination of multiple policies to keep our students and faculty healthy and workers healthy. And it involved masking, it involved routine vaccination, regular testing, and isolation upon testing positive for SARS-CoV-2. And all of these taken in combination, whether it was testing at arrival on campus, quarantine after arrival, and then routine testing thereafter, was to keep SARS-CoV-2 from spreading within our campus, keep it from spreading within our classrooms, and from within the residencies on campus. Okay, so I was asked, or I volunteered, to analyze the data from our campus to look to see if there was a transmission, in this case, associated with residential housing. So we got almost 6,000 SARS-CoV-2 genomes from UC San Diego undergraduate and graduate students. And for 18,000 of those, sorry, for 1,800 of those students, I was facilitated with information on what building on campus they resided in. And for most, but not all of those students, that information came with what specific room on which floor they resided, and in which suite, because often you'll have different rooms connected by a shared suite, shared bathroom, shared kitchen, etc. And then we also know what floor these students resided on. And the question we wanted to ask is, was there sustained transmission in campus housing? Now, most of these data come from the Delta and Omicron waves. Prior to that, there wasn't the same type of record keeping, and also there was case investigation for every individual who tested positive on campus. During Delta, that case investigation waned, and during Omicron, it all but ceased because, like everywhere else in the county, we were just simply overwhelmed and weren't able to follow up on every individual case. Okay, so of the data I'm looking at, about 5% of them are Delta, but really this is an Omicron story. This is 89% of what I'm about to tell you happens during the Omicron waves, which in this case include BA1, BA2, BA4, and BA5. So going up through August of 2022. And as you can see here, the genomic data bear that out, where you can see just a tiny little bit of pre-Delta, and then we have the Delta wave, and then those sort of large clusters surrounding all of this phylogenetic tree are BA1, BA2, 4, and 5. And of course, BA1, you may remember there on the bottom, has near genetic identity because it swept through so quickly, the virus just didn't have time to mutate. Okay, so we looked at all of the students who we had housing information, and we counted the number of genetic links that they had. Now, what we notice is that most students had a 0 or 1 genetic link to another. So their viruses, again, were very genetically dissimilar. And we could ask, well, if they're in the same building, that probably means something. But of course, many of these students also had BA1 Omicron, which meant they could have 200, 300, 400, even up to 735 genetic links out of 6,000 people. So some of these links aren't very informative. Now, of the 700 or so buildings on which students resided on, some of these buildings contain a lot of students, with SARS-CoV-2 over this period. Some buildings really only house 1 or 2 students. That's mainly graduate housing, but of course, others we can have scores and hundreds of students in, and scores of them could have SARS-CoV-2 infection over this observation period. Okay, so we have kind of 2 different types of student interactions here. We can have a student who has 1 genetic link and a single infected suite mate in the data set. Well, that seems, well, you can ask, like, what are the odds of those 2 people being part of a real transmission pair?
Never tell me the odds.
Not so much odds, but it's probability. And basically you want to know, like, what's the probability of that being a false positive? And well, if it's 1 over 6,000 and then 1 over 1,800, you multiply that together, and there's no way we're looking at a false positive here. These 2 people are as consistent with a transmission cluster based on genetics and epidemiology as you can imagine. But what about those people that got, that sort of base Omicron sequence, and they had 735 genetic links? And what if they happen to live in one of those tall tower buildings where 5% of infected students also resided? So now what we have is 735 genetic links. So we're going to flip a coin that comes up heads 5% of the time, but we're going to flip that coin 735 times. Now we'll just pause and wait for Javier Bardem to flip the coin 735 times. Oh, no. Okay, so we got a heads. All right. Only happened 5% of the time, but with enough coin flips, you're going to get a link. And in fact, for these people, we'd actually expect 99% of the time, even if you randomly shuffled all of the data across the phylogenetic tree, everyone's housing, they're still going to link to a building mate or even a floor mate. So 99% of the time, you're going to get a false positive on these individuals. So it's not really informative data, and we're going to ignore those instances here because we just can't distinguish transmission from coincidence. So we're going to stick to pairs of individuals who, based on their connectivity to a suite mate, floor mate, or building mate, you would have expected them to have an identical or near identical genome less than 50% of the time. So what does that tell us? Okay, now let's look at roommates. We had 55 roommates who had COVID diagnoses within 2 weeks of each other, and 47 of those roommates had genetically linked strains. So that's kind of what you would expect. If you live in the same room as someone, I can't spell roommate apparently. If you live with someone and you both have SARS-CoV-2, well, odds are you gave it to them. As we know, most transmission happened within households, and a room where you share multiple beds in the same room is kind of like a household. So that's transmission. But what I think is really notable here is that in 8 of these instances, these roommates who had COVID at the same time or within 2 weeks of each other, a genetically unrelated virus. And when I say unrelated virus, I mean like very unrelated virus. Not like, oh, it's just another mutation and maybe we missed it. It's like, no, these 2 people have very, very distinct versions of, in this case, BA.5 Omicron. Now, is it possible that the samples got mixed up and the student IDs got shuffled around and that's not actually the viral genome that belongs to that person? Yes. It's also possible that it's Omicron and people got SARS-CoV-2 and coincidentally, roommates got it independently and brought it back. And I think that's what happened 14% of the, 14% of the time here. Okay, so let's look at suitemates, a word I know how to spell. So these are inclusive of roommates. They have beds that essentially have the same address on campus, but they don't necessarily sleep in the same room. They may have separate doors and separate bedrooms. And in that case, 144 suitemates were genetically linked to the virus from their suitemate that had COVID at the same time. But again, that means 25% of suitemates sort of coincidentally got this virus at the same time. All right, now when we move out to the level of floors, now this is only buildings that have floors now. We had 1,800 floor mates have COVID at the same time, but only 26% of them were genetically linked to each other. I just want to show this drop off here. When we look at roommates, 86% of the time genetically linked. Suitemates, 74% of the time genetically linked. Floor mates, only 26% of the time. Now that's inclusive of your suitemates and roommates, which means not really looking at a lot of transmission across shared floors. That doesn't say we're seeing none, but if we zoom in here and we look across the floor mates, we can see that 284, 26% of the time, and we would have only expected, based on that sort of shuffling I talked about earlier, 71 links among floor mates, maybe up to 100. So we definitely see more transmission across these floors than you would expect. And when we go to the building level, we see a decrease again. Now only about 19% of people who shared the same building were linked to each other. Now that's inclusive of the 284 who shared a floor and suite or room. So there is some evidence for transmission across floors and across buildings of people who weren't in the same room. But what I'd like you to look here is at the very top. Those are people who just happen to share the same college. That's undergraduate or graduate college. And we see that out of the 19,000 or so links that occur, 3,000 out of the 24,000 links, 23,000 links, 3,000 people who shared a college are genetically linked to each other. Now, these are mostly people who weren't in the same building. So this should give us an idea of the sort of the background local community transmission rate among these students, because simply belonging to the same college doesn't give you exposure, but it does mean that you're socializing in the same places, you're more likely to be eating in the same places, potentially in the same classes, although I have my doubts that we had much classroom transmission at all. So there is some sort of baseline level of transmission, that 15% just by being in the same college. So our elevation in buildings over colleges is only about 4%, meaning I don't think we had a lot of sustained building transmission. But that led me to look at these data a whole different way, which asks, do we see persistence of SARS-CoV-2 within campus housing. So I went and I built phylogenetic trees for each of the Omicron variants, and I mapped every building, floor, and suite onto these trees. And I looked to see at what point in the phylogenetic tree did SARS-CoV-2 find itself in a building where we could infer the ancestor of that virus was in that building, and then it continued to spread. And if we zoom in here into BA2, we can see right there, that's an introduction into a building on campus where you have five students who are all in the same building and all have very, very closely related SARS-CoV-2 virus. So here we have an introduction of a virus into a building where it stays. And we found 61 Omicron clusters that entered, that were introduced into and persisted in campus housing. 37 of these clusters were contained entirely within a single suite, which means essentially the virus got into a suite, it transmitted among people, and then we saw no evidence for continued transmission to another floor, within that floor, or to another floor in that building. Now, of course, as these students became infected and diagnosed, they were moved to isolation housing or told to isolate in place. So apparently, in these 37 cases, mitigation strategies worked and transmission was halted. We saw 14 clusters where viral transmission seemed to have taken place across the same floor of a building. And we also saw 14 additional clusters where there seemed to be transmission across different floors of the same building, which is notable, indicating that we may have had transmission within shared parts of the building, or we cannot rule out people visiting each other's rooms, etc. Okay, now for one example where we saw this virus move across floors in a building, it's between two suites that we know share a private stairwell that other residents of this building would not use. So now that could indicate socialization across, visiting people who you share a stairwell with, or persistence of this virus and acquisition of this virus in a shared airspace. We can't tell the difference here. We also saw, I think, a very telling instance of individuals in the same building, but not the same floor or suite, infected with nearly identical virus. But this was housing that had different external entrances. This is essentially two apartments where the external doors are adjacent to each other. Now, is it possible that the virus went out one door into the external environment and through back into the other? Maybe. More likely that people hung out with their next door neighbors. I mean, you decide. Okay. But here's the question I have, is that how long did this virus persist? Did we see this virus within a single building and we see infections week after week after week? Well, not really. So the longest time span we see for any building cluster is 20 days. That's 20 days between the first diagnosis and the last diagnosis within a building. But this 20-day long cluster, all of these individuals resided in a single suite. So there's no evidence that this virus was transmitting across a floor or throughout the entire building in this cluster. All cases contained to a single suite, so we probably see progressive infection and diagnoses among the individuals in this suite. The next longest persisting cluster was 18 days between first and last diagnosis, but that was within, again, a single suite, but it did spread across the floor to the suite next door to them, indicating, no, we're not seeing sustained viral transmission. Again, this is probably indicative of socialization, or at least contained virus across these across campus housing. And importantly, out of the 61 building specific clusters, 34 of them had no additional diagnoses more than 3 days after the first diagnosis, and 50 of them had no additional diagnoses 7 days after the first, indicating that even during the Omicron waves, we don't see evidence for this virus sort of persisting and continuing to transmit within campus housing. So, even in the face of Omicron, do we see SARS-CoV-2 persisting in campus housing? I would say no, and potentially only in very sort of isolated instances with limited numbers of infection. So I think this is a sort of a gold star for a return to learn, especially during Omicron, where we knew with sort of widespread community transmission that we weren't going to have students not getting infected with this virus, but we were able to prevent sort of widespread transmission within the residences on campus. Now, this is a very, very preliminary look at the campus housing data, and there is a lot more to come, and I'm still interrogating these data, but I just wanted to take the opportunity today to share my preliminary findings with you and know that we're continuing to work on this. So with that, I'll take any questions you may have, and thank you for coming to iRounds.
Thank you, Joel, for an excellent presentation as usual, with always wonderful visuals. So we appreciate that. I guess we can open it up. I know maybe Joel, you can take a look through some of the chat, and I think Francesca helped out with answering many of those questions. But I'll go ahead and just open it up to see if anyone wanted to unmute, or perhaps I know Shannon, you asked a few of the questions. Did you have any other questions you wanted to pose?
Yeah, I see here. Yeah, my co-authors, Francesca and Lucy, it seem to have done a really great job there. They, of course, have a lot more expertise on the inner workings of the hospital system than I do. I just look at the viruses and tell you what story they tell.
Any questions? So I'll ask one. What's your next step with all this?
So with the healthcare data, I think we've that paper is in the sort of the publication gears, and we haven't looked at the data since the first Omicron wave. So if people are interested in that, certainly have all the tools to do it again. On the campus side, what I'm very much interested in is looking at sort of other connections on campus, specifically within classrooms, because we had excellent masking policies and adherence within our classrooms, but we did see a lot of transmission links across within the same colleges among students. So I think it's worth asking whether or not that was classroom mediated transmission, although based on the limited data I've seen and my own experience teaching undergraduates on the campus, I think that we likely averted within classroom transmission when universal masking wasn't.
Great. How do you think this data informs us in regards to on the healthcare side of things in terms of future masking? I mean, I know right now the guidelines are still recommending, in person when medical providers are in face-to-face with a patient, that we're still recommending masking.
Yeah, well, I would say, and I'll let Francesca jump in after, but that we really do see effectiveness there, and that there were a lot of patients with COVID. There were a lot of healthcare professionals with COVID, and yet we didn't see transmission when universal masking. And I see this as a very convincing observation that masking works extraordinarily well in that setting, because otherwise we would see what we saw in household transmission. We didn't see that yet. And I'll turn it over to Francesca.
Yeah, so I think I echo what Joel says, and I think that the data collected on campus, but also the data in healthcare, where we know that certain administrative controls are present, right? Aeration is by regulatory has to be really at a certain level. And so we have that advantage in healthcare, but it also means that we have that opportunity of really maximizing ventilation and then using other controls, engineering controls like source masking and protective masking, universal masking, in other settings like schools, right? So we don't, what I would say is that aside from politics, we know what works. And so we should, as a progressive country or a progressive institution, we should really push that. And so that is where we pivot our paper in really going to that and trying to answer or guiding those policy decisions based on this very exhaustive data that we have.
Great.
There question from Anik in the chat.
Yep.
Oh, sorry.
Yep. Please.
Yeah. So yeah, and Anik asks if the sequence similarity due to Omicron, specifically BA1, was due to its efficient transmission and it didn't have time to mutate, or was there something more inherent to the strain? And the answer is the former. It just burned like wildfire. It arrived here very quickly, and the same identical version of that genome arrived in San Diego repeatedly and then spread within San Diego repeatedly. And it did the same all around the world. So basically you just have transmission that is so rapid. I mean, that wave happens so quickly that, you know, in a matter of weeks or a month, the virus would only pick up, you know, a couple of mutations anyway. So half of the people who get that virus have identical or nearly identical virus. That's not to say there aren't sort of distinct clusters in there that you could find. It's just that about a third of them, or maybe a quarter, are indistinguishable, just because it was the epidemiology was so fast. You know, the immune escape was so complete that it basically treated us like kindling, in my recollection.
Thank you, Joe. That makes sense. I just wanted to check.
Yeah.
Great. Any final questions? All right. If not, wanted to thank Dr. Joel Wertheim again for an excellent presentation as usual. And as a reminder, please go ahead and register your attendance if you are asking for CME. The number today is 443, and you can text that to the number that's in the chat pod. Hopefully we will see you next week at High Rounds. Thanks again, and have a good afternoon.